Okay, thank you. Commissioner Lee.
Hello, I thought I would pop in here for a little bit. Y'all got some interesting topics on the agenda, and I wanted to make sure that that you all know that I listen and I'm here, even though I'm not in the meetings most times. But definitely am interested in the vaccine and some of the community health worker topics. So I think I might have a little bit to contribute today to that.
Okay, awesome. Thank you. Meredith.
Afternoon.
Ron, it is now 1 o'clock and the waiting room is cleared. I only show yourself, Rosemary, and Meredith as committee members logged in. If I missed anyone, please let me know.
Hopefully we'll have somebody joining us because we need one more for a quorum, right?
Yes.
Okay.
I will keep an eye out.
Jill definitely won't be on. She's on vacation. She let me know that ahead of time. Paula hopefully will be on, and Mr. or Philip also hopefully, or Matt will be joining us. But
I'm here, Ron.
anyway.
Oh, I was going to say
Okay.
Matt just joined us.
Awesome. Okay, at least we've got a quorum. All right, just want to call the meeting to order. Wish everybody a happy Valentine's Day. We do have a quorum, and do I have anybody who, when I sent out the minutes, that needs to make any changes to the prior minutes from December? Okay, without hearing any changes, do I have a motion to approve them?
I make a motion to approve the minutes.
Okay, motion by Rosemary. Do I have a second?
Second.
Second by Matt. Any further discussion? All those in favor say aye.
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 Aye. Okay. Any opposed? I believe I heard Philip's deep voice on there, so we got 5 of us on here now. I just wanted to give Medicaid the opportunity to on the change for fee for service from Magellan to MedImpact. Is there any updates or anything that you all need to let us know? I just put it on there because it seemed pretty seamless on our side. Didn't know if there was anything else we needed to help you out with on that change. And Commissioner Lee, I didn't see Fatima on here yet, but I didn't know if you wanted to give us, if there's any problems that you all incurred or anything you need our help with on that change.
I don't think so at this time. From everything I heard, the transition's been going pretty smooth, and for you all to say it's seamless on your side, that's wonderful news. We will continue to monitor and reach out if we see any issues that we think that you can assist us with. I think there've been, 1 or 2 major, not minor little things that we have corrected in-house, but other than that, no major issues, but we'll definitely let you know if there's something that we think that you all can help us address.
Okay. And Commissioner, on that topic, even though this is just, I've had a couple people that do service, fee for service, facilities, and see a lot of fee for service residents that are, trying to, engage with their physicians on providing the vaccinations. Is that active now? Like, is there coverage for the fee for service people for vaccinations by a pharmacist?
Um,
'Cause I know it was approved, but I didn't know when it got activated.
I'm not sure. I'll have to follow up on that. I just want to make sure that it's for individuals who are in facilities, or the pharmacies going into the facilities, or the individuals are coming into the.
Either way, if they are fee for service right now, or well, it used to be that there was not reimbursement for pharmacists providing that a vaccination, but you all did change that. But I did have uh, Paula Miller from Rui Pharmacies in Northern Kentucky. They service quite a bit of long-term care, and at this time they still could not bill a claim. Now that was as of a week ago Monday that I talked to her. So if I could just get an update, because I mean it already got approved. I thought it was already active, and and I don't have anybody to remind. I mean, I didn't have any. Oh, Ben's got his hand up. Do you have an answer there, Ben?
It is not active yet. I had a member reach out this week that it's still not working. So I don't know what I think it'd be good to get an update on when we think that's going to go into effect, or if anything we can do to help. But I can't say it's not active right now.
I'll
Okay.
follow up with the directors.
Okay. And if
At this time, it's just COVID vaccinations are the only ones that are covered through pharmacy. But I'll get a better update on a time frame we can look to.
Okay. And then Commissioner Lee, all you got to do is, if whatever update, just let Ben know, and he can get it out to all the pharmacy and Rosemary, Ben and Rosemary both.
Okay, thank you. Yeah, I'll follow up on that. And thanks, Jessica, for that information, and we'll circle back with you.
Okay, thank you.
Commissioner and Ron, if you don't mind, I'm sorry, this is Erin. Guys, if you're not speaking, if you don't mind to mute, there's some feedback and mumbling in the background, and it makes it hard for the court reporter to capture everything.
I'm
Thank
sorry.
you. Sorry to interrupt.
That might have
that's
been
fine.
mine, Aaron. I think that I'm in a cubicle, and all of the individuals walking back and forth may have made that noise.
Yeah, I've barricaded myself in the break room back here, hopefully to get some peace and quiet. As far as the community health worker discussion, I know Justin Derringer's on the line here with us. Justin, you got your hand up.
Yes, sir. How are you? Can you hear me?
Yes, sir. Go ahead.
Good, good. Yeah, I wanted to start off by saying I know that the pharmacy billing for vaccine is in the works. I think it's in the program area as far as the system change part, and so that is I can't give you a time frame. I'm not sure if we never really get a time frame. We put the system changes in, and then they go into effect at whatever point the system team can get those into place. But those are done, and those are usually backdated to whenever whenever those are first approved. So we can kind of get you that date moving forward.
Okay. And Justin,
yep.
what's if I'm sorry to interrupt. Is it going to allow pharmacists to be able to work with our community health workers on carrying out the various duties and being able to control those orders, or what are you all seeing as the best or the fit for pharmacists to get involved?
So that update was for vaccines. For community health workers, I believe that proposal is still being reviewed and looked at as to how best to implement that. So I don't know if we have any conclusion to that right now.
Well, I just want to put it in your ear that if we as a group, pharmacist practitioners, if we need to do something statute wise, I would really appreciate you, giving us a heads up, obviously, as soon as possible, uh, so we can get those changes made. So if there's something that ties your hands behind your back or whatever that don't allow us to do whatever, I just appreciate you just giving us a heads up saying, hey, if you all take care of this, in this regulation or statute, that would really free up for pharmacists to work with our community health workers.
Yeah, absolutely. No, I think we've got what we needed in the regulatory part. And so right now we're just kind of in the research stages. Whenever we add something new, it's a lot of research and development, trying to put it all together and come out with a correct policy and limitations and all that kind of stuff. So that's kind of where we're at, and still in the developmental stage of that.
Okay. And Justin, since I was in my mind, on a completely different topic when you gave your first answer, could you review again about the vaccinations for fee for service, what you said, please?
Sure. So that's it's in the process of being changed. We give the change orders to our system analysts. They make the changes in the system, and of course, as you can imagine, there's hundreds upon hundreds of those changes. They have very limited staff, so it's put in an order, and then it kind of, as they get it done, is when it goes. So we can kind of get you a date of when it will be backdated, but we can't really give you a great date of exactly when it's gonna be live or active.
Okay. Well, and there's obviously the priority you all had was to get everybody switched over from one carrier to another. So you had that in the way at the same time you're trying to make these changes. So we understand. So, Ben, you still have your hand up. Is there something else you wanted to add?
Nope, just don't know how to use Zoom.
Commissioner Lee, go ahead.
Thank you. I just wanted to add on to Justin's community health worker topic. I have a few stats I think might be interesting for you. Since we allowed providers to begin billing on July 1st of 2023, 39 providers have billed for community health workers, totaling approximately $35,000 for about 1,218 members. So as Justin said, we continue to look at the community health worker policy. There would not need to be a statute change. But I had a conversation with national leaders yesterday related to community health workers specifically, and we do have some plans to talk to a few states who have been allowing pharmacies to order community health worker services. So again, just wanted you to know that we are looking at that, and wanted to, if I could, just revisit the vaccine. So we're just talking about the vaccines for fee for service. We're just talking about those that are in long-term care facilities right now, or in facilities. Because I do know that there was a recommendation made to allow pharmacies to cover a broader array of vaccines within the community, within your pharmacy settings. So I just wanted to make sure that we weren't confusing those two things. So what we're talking about right now is just the fee for service.
Yes.
Okay.
Yeah,
right.
we're fine on the other side.
Okay.
And again, where this is developed is because a lot of doctors or a lot of physicians who are over long-term care units, they've grown accustomed to pharmacists doing or performing vaccination services of all the different vaccines we can provide. So, they just give the order, hey, talking to, especially like Paula Miller at Ruiz, saying, hey, Paula, we need to provide this coverage. Asking them to go ahead and do it. And then she's got to tell them, well, we got to wait till this gets covered under our fee for service, because right now it's still going to have to be under a physician. So that's where it's coming from. It's not really that the pharmacists didn't push for it. I think the physicians are pushing for it because they've just grown accustomed to that service provided by the pharmacist. So
Thank you for that background.
okay, you're welcome. If anybody else wants to comment on our HPV vaccine update, we've had another meeting, very good meeting. Dr. Theriot is working on the protocol as we speak. I think everybody who's been on those calls, everybody just, we just think of all the considerations, and I know she's working on that right now. So, but I appreciate Anthem and all the other MCOs that that's put their 2 cents in and trying to work through this. So I think it's going to be a big success, and hopefully we can move the needle and the mark on getting that HEDIS scores, state HEDIS score on HPV up quite a bit. So does anybody else have any comments to make about our meeting or the status? Okay. And then Ben, I just put it on here to make sure that we still weren't having issues on vaccine counseling billing standardization. I didn't know if obviously you all have been fielding all the phone calls on it, Ben. So I didn't know if we had a few MCOs that people are still struggling with, or if there's a lack of standardization between the MCOs. I just want to give you opportunity to comment on that.
Thanks. I think at this point we've worked through the process with most of the MCOs, and we're just working to spread the message that folks need to start it, billing for these encounters, and if there are one-off situations, then we'll work through those. So I know we've seen paid claims from, I think I could say 4 of the 6 MCOs at this point.
Awesome. Great.
Thanks.
And I just got some same FYI down there for people's resources to look at things there. The only thing I'm still trying to work, just to let Commissioner Lee know, I'm still trying to work with my pharmacy software system, because obviously there's 4 pretty popular systems statewide as far as independents, and then of course each of the big companies have their own software too. But I'm trying to find a way to streamline that, looking through the database using our software systems to find those claims that we can identify and rebill. So I'm trying to work at it from our side to utilize that database. So just to let you know what I'm trying to work on there, because at first I was thinking, well, we could get some help from the Med Impact side, but really, when you're dealing with when you're dealing with probably 10 different software systems, pharmacy systems, it makes more sense for us to maybe look from our side to try to simplify things. So just wanted to give you an update on where I was thinking on that.
Thank you. And if you do, come up with some that you need us to help do a little bit of research, if you provide that example, we can definitely help you do a little bit of research on our end.
Okay. Thank you very much. Okay, Rosemary, on the cost saver plan under new business, I've been exposed to that a little bit, but I think you've got more details than I do on it.
I've had our members from across the state for the last, I guess, 3 weeks, bring this to my attention about this, the Caremark cost saver plan. And I know I was on a Zoom call with Commissioner Chamness to discuss, this issue. And I just wanted to bring this up. I think it's very concerning to independents, across the state, that all of a sudden we see, and I have many examples of this, that our patients' copays from December to January, even though the state was told on the state employee health plan that their copays, that their members would be saving money. But I have been able to show the commissioner that, in fact, that is not happening, that I can compare December claims to January claims. And in most instances, the copay for the patient is higher. But in every case that we find this issue the pharmacy is being clawed back money. And obviously, we're not sure where the money's going. It's supposedly being, our claims are being rerouted to GoodRx, who then is rerouting them to a number of PBMs, I think Express Scripts. So I think it's very concerning to all of us that, and I can show examples from our pharmacy that, we were losing money on the first claim, and then we're losing that extra $7 or $6 or $5, that much more on the second claim. So, I think, where is this money going? Why are we being forced to accept a discount plan that none of us accept across the board? So I just didn't know if anybody else had any comments about this from perspective of providers.
Well, I'm with you on this. I've been working with John Gentry here in town and some other pharmacies, because it takes all of us to figure these convoluted plans out like this. But this is a case where one of the big three PBMs are actually making money off of 8 other PBMs and, like usual, pharmacy providers. Greg Rybold is a legislative affairs director for a buying group in Alabama. I had a long talk with him about this, and I set up a meeting with him and the FTC, because Greg was so much more well-versed in all the different avenues that this entails. I think Ben has a really good analogy about, when somebody wants to question, say, well, doesn't it still save consumers money? I think Ben puts it a lot better than I can, but yes, there's been a bunch of work done on this, Rosemary, and the meeting between Greg Rybold and and it's actually the investigative body for the FTC on the PBM 6B study. They had an 1.5-hour meeting on this topic. So that's pretty good news, because this is something that was brand new to all of us. And unfortunately, our state employee system is part of it. And the bad thing is this particular plan is intertwined with other larger contracts. So somebody cannot just opt out of this particular contract that actually is taking money away from our customers. We know it's always taking money away from us, but when you see somebody having to pay a $20 copay when last month they paid $10, and then they're clawing back $10 and $12 of that, I don't think it's a convoluted mess, but I don't think it takes an Einstein to figure out, the money's being pulled back from both the patient, or the patient's paying more, so more money can be pulled back and shared with all these different PBMs. So it's frustrating. Go ahead, Ben.
And the context of this in Medicaid is for those people that might be dual eligible, right? So you have to let that claim stay adjudicated before you can bill Medicaid secondary. Is that the problem as it relates to Medicaid?
I believe so, and I think it's easily inflated the cost of Medicaid, because again, Rosemary's already pointed out, just in her own pharmacy, showed where those claims are higher now than they were a month ago. So obviously, if you're billing that secondary, which is just an inflated price in order for the clawback fee to be taken away from the extra cost on a copay to the patient, and then Medicaid's picking up the difference. I mean, that's a big consideration.
I think the plan itself, this whole structure is horrible. We saw night and day difference. I have a patient who is recovering from cancer, single mom with 4 kids, and her out-of-pocket costs skyrocketed because instead of paying a copayment, we adjudicate a claim, and then there's a post-edit adjudication that occurs, that because we don't have contracts with GoodRx, but it goes through this separate system, price shops, comes back with a cash price that they think is good, and they forward it to her, and like, hey, we're saving your plan money, but now you've got to pay this much. The part that's really difficult is what we have to tell the patients. I do think it can be bad for Medicaid as well, but it's just bad for patient care. And unfortunately, a large number of patients we're seeing are Kentucky Employee Health Plan. And this was not anything they signed up for. And talking to these people, these changes just occurred behind the scenes to save money. And the part that really irritates me as a pharmacist is that we're paying some of these. I've seen like $5 adjudication fees to a third party that does absolutely nothing. And they get a rebate on this, and they're doing nothing, but we're paying them to pass this to another third party that we don't intentionally do business with. Anyway, I'm gonna get off my soapbox now, but I think it's like this.
No, I appreciate your comments. It's look how many people it's affected already. I mean, the different people we have on this committee even, and everybody's being affected by this. So hopefully, Commissioner Lee, if we can get to the bottom of this, and again, I think it was just that much more information that the Federal Trade Commission took in to their, I mean, this Greg Rybold said there was some pretty ugly comments made about this particular plan after they questioned it and got to the bottom of it. But you're dealing with, as far as it's been documented, 8 different PBMs plus GoodRx. It's convoluted is not even really describing how crazy if you had to follow the money. Because I've had a pharmacist friend of mine call up the PBM who he originally adjudicated with, and the fella said, I'm not seeing that claim. And that's who he originally sent it to. And he says, I've got the response here, and it's telling me it's going through, it doesn't make a difference, XYZ PBM. And he goes, and the guy on the other end who he originally sent it to is like, I'm not seeing this claim. So it ought to tell you the unbelievable digital mess that's put in place just to deceive and claw back more money from our patients. And it's crazy.
Ron,
Yes.
I was on a call yesterday with NCPA, and we were discussing this matter, and they, the officials there were saying that 3 or 4 states have already somehow gotten this turned off. Now, they didn't know the particulars, and I haven't really had a chance to get into that, but evidently this is not just Kentucky, it's across the board. And there must be a way that we can get this turned off, but I don't know how we can do that. I don't know if anybody knows anything about that.
Well, if you could share your contact with me and Ben and whoever, all of us can try to contact NCPA and try to figure out, get to the states that were able to do something. Go ahead, Matt, you got your hand up.
Thanks, Ron. I just kind of, like Ben said, I want to kind of put this in context of how it relates to Medicaid, just to wrap it all together. Because for those of us who are on the front line, we're talking shop and we all know what we're talking about. But for someone who might not be, they might be confused about what we're talking about. So Caremark put in GoodRx to help lower some of the cost. And it with the state employee plan, which is the largest commercial plan in the state. So they are raising the cost. They send us negative reimbursement. So we're basically paying for the prescription to go up. When it's a dual eligible, we're sending that claim to Medicaid. So GoodRx is raising the price of it. Then during the clawback, they're taking back part, if not all, of the dispensing fee that Medicaid's paying us. So Medicaid's paying GoodRx to raise the price of prescriptions, is how I see it relating to Medicaid and an issue going on there. So we're basically paying another PBM or more to raise prescriptions and pay us less.
So you mentioned the GoodRx part of this is clawing back the Medicaid dispense fee?
when we say I just bill, I'm just going to use arbitrary drug names and prices here, but say I bill lisinopril, they'll send me back -$7 and then make the copay 10. And then when we bill it to Medicaid and we get paid 1064 plus the cost, they're taking back 7 of that 1064 that Medicaid's paying. So we're basically getting at that point $3.64 dispensing fee. So we're kind of getting middlemanned out of the dispensing fee that we fought to statutorily have.
And is this part of a primary payer that you're billing to initially, and then Medicaid is a secondary, or is this all Medicaid?
It's primary payer, so it's through Caremark commercial plans, and then I'm not sure if all of them signed up for the GoodRx, but I know the state employee plan did. And then when you bill Medicaid secondary, the dispensing fee, it's getting part of it, depending on how much they call back for that script, is going to GoodRx, or it's going somewhere. It's not going to us. Whoever GoodRx splits their money with. It's a very tangled web. But I think that kind of covers how it relates to Medicaid and the issue we're having, unless someone else needs to correct me or add something to it.
Commissioner Lee put a note in the chat that she's going to be checking with her people on this and just seeing what can be done. And obviously we need to check on our end, work with NCPA. If other states have been successful in getting this plan turned off, which is nothing but a bump up to make the PBMs more money at the cost of both the provider, us, and Medicaid, we need to certainly work together on this.
And is this the Kentucky State Employee Health Plan, or is this somebody else?
It's one of the plans that has this. There's other Caremark commercial plans that have it. Like I said, I'm not sure of all of them, but the state employee health plan definitely is part of it.
Okay, yeah, we have some contacts and we can probably reach out to them as well.
Okay. And on the second topic there, Rosemary, I was just going to let you set that up.
Sorry, I keep bringing up everything today, but I just keep hearing from members all across the state. I guess this started again, January, the first couple of weeks of January. I had my KIPA members contacting me about, it turns out it looks like these are Medicare Advantage plan, dual eligible patients. And the products, after we finally started tracking this issue down, are DME products, mainly diabetic supplies. And all of a sudden, you can compare again claims from December of last year to January of this year. And where the patient, a dual eligible patient last year, had no copays, this year, all of a sudden, there are these large copays that are coming back to the pharmacy saying that this dual eligible patient owes this copay. And I've had members spend hours on the phone. The first couple of members that told me about this were on the phone and finally were given an override from Anthem. And this is, so far it's been Anthem that we've seen this for. And I think that what was really distressing to me was not only the time they spent, but after they received the override, which meant they didn't have to charge the copay, there was almost a threat that you're not compliant. This pharmacy is not compliant and you're going to be reported. And then some of the same patients that were involved, because the pharmacy was trying to get these patients their strips or their Lancets or whatever. And the patients, I guess the patients must have called and reported and saying, I shouldn't have a copay, or why am I having a copay? And a couple of the patients were advised to find a different pharmacy. And that, to me, that wasn't the issue. The issue, I think, is with Anthem. And I've sent a lot of, just today, I was able to get examples to Dr. Ali and to an Anthem representative. But it's a pretty widespread problem, and it's from different areas. I mean, different parts of the state, but it's hard to explain without seeing exactly what's going on, because sometimes it will come back and say that you can't bill the patient the copay. You have to just take that loss. So I just wondered if anybody else was seeing this, and how could we resolve this issue?
Yeah, so I see Angela Kamerley from Anthem is on. I don't know, Angela, if you had time to look at some of the examples that were provided, but any updates you can provide would be appreciated.
Yeah, thanks, Fatima. And thanks again, Rosemary, for getting those examples over this morning. That helps a lot. We are looking into the examples that you shared and we'll communicate out once we hear something. We are engaging different teams at this time. So we do appreciate you letting us know that this is occurring.
Okay. And then, Angela, if you can just, give Ben and Rosemary an update whenever you can figure this out. Because obviously this is, we're just trying to provide the same service that had been provided in the past at zero copay. And obviously these people are wondering why all of a sudden there's a copay, and we're trying to go to bat for them. And seems like we're kind of being shaded that we're doing something wrong when we're just trying to get stuff paid for the patient. So.
Ron,
Oh,
one
sure.
of the,
I understand. I'm going.
sorry, one of the examples I had was from the same pharmacy, and they were patients, the exact Ben, PCN, and group number. One patient was dual eligible. The other patient was not dual eligible. Both were getting diabetic test strips. And the patient that was dual eligible, who in December had no copay, had a large copay in January. The other patient who was not dual eligible in January had zero copay. So that didn't make sense either. The patient that wasn't dual eligible had a zero copay. So, but those examples have all been provided. So hopefully we can get to the bottom of this.
Okay.
Yes, and thank you again, Rosemary. I will reach back out.
Okay, thank you. Okay, does anybody have any other business to go before our committee today?
Hey, Ron, quick question, and it may be something we just need to add for future discussion, but
Okay.
On the beginning of the year, when we see changes to NADAC and WAC and the pharmacies were reversing claims and they were taking that out of their payments the next week, but then they didn't get paid for the new claim until 2 weeks later. I wonder if it would be possible to make a recommendation that when claims are reversed, that they sync those two up. Like, even if it means that, I understand it takes 2 weeks to put the payment in process, but is it possible to delay the reversal of funds by an extra week at certain parts of the year to try to accommodate that? Am I making sense?
Yeah. Basically, the money's taken out immediately on the reversal, but you're not getting paid for 2 weeks on the new reimbursement. Is that what you're saying? So we got a cash flow issue.
Yeah. So is it possible to work with MedImpact to sync those transactions up, even if that means holding the reversal for an additional week so that, pharmacies aren't impacted immediately and then getting the money 2 weeks later?
Fatima, can you speak with MedImpact or
Yeah.
I know we're not going to get an answer today on that, but
I know some folks from MedImpact are on, but it's probably something we have to take back unless MedImpact has any thoughts.
okay.
Okay, let us take that back and we'll follow up.
Sorry,
Okay.
Fatima, I was trying to get off mute and it was not working. Yeah, we will have to take it back because that's the way that finance works for all of the MedImpact contracts. So that would be a large change, and And I don't know if it's just been more prevalent because there's more NADAC changes for large dollar claims that you guys are seeing this now, because a lot of them that we're seeing are for claims that are over $1,000 and the NADAC has changed. So I think that's really been the largest impact here in January. But we can take it back and inquire.
Yeah, we would appreciate any consideration there. So, and if you need, if you need examples or what have you, obviously Ben and the rest of us can work hard on getting you some examples to just look at the data and how the difference in time frame on that.
Oh, I have plenty of examples. I've been working with all of the pharmacists. Yeah.
Okay. All right. Thank you. Anything else anybody has? Okay. Just update, March 28th is the next MAC meeting. I'll be either providing my report to our pharmacy representative on the MAC, or I'll present. And then our next PTAC will be April 3rd. And I apologize to everybody. Fatima and I worked out a great deal that I delayed this meeting for a week. It just would have been nice if Ron would have gone ahead and informed Aaron and everybody else about the change. So that's my fault. So I apologize for that. I just think you're all clairvoyant and can read what's going on in my mind. So anyway, do I have a motion to adjourn?
Motion.
Motion by Phil, second by Matt. All those in favor say aye.
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 Any opposed? Happy Valentine's Day, everybody. Thank you.
See you, Ron.
Thank you.
Well.
Thank you.
All right.